Lucica Ditiu has been working in tuberculosis and lung disease for several decades. She's a doctor in pulmonology and also has a certificate in international public health from the George Washington University in Washington, D.C., which I only mention because I'm also a student there. So we're very proud of GW. She has been working with, she worked for a long time with WHO, now works for the Stop TB Partnership, where she is executive secretary since January of 2011. And she's going to talk to us this morning about the global burden of TB, which I think is a good way to start, because some of you are very familiar with the situation in your own country. For those of you who aren't, or who are looking for the latest numbers, we've got the expert here, so thank you so much.
Thank you. Thank you very much, all of you, for being here. But most important, I want to thank to our colleagues from the Press Foundation that are putting together these yearly meetings and briefings and training. And I think this is extremely important because then you can take this and run with it. And I used to start this by saying that in TB, we are in so much need of visibility and support in terms of reaching out to the minds of people, being them ordinary people or decision makers, that whatever you will write will be good. So feel free to, we are at a moment in time in which I think the more we can have coverage and information, right information about TB, the better it will be. And actually, you will see that in my presentation, I will speak to some facts about TB. I'm not entering into a piece that is extremely important for us, which is research and development. And that's because I'm here with my friends from TAG, Colleen and Mike, that will speak about that piece. And more than that, that will give you an opportunity of direct or live reality checks to say so, because they will let you know that actually today, TAG, Treatment Action Group, came up with a report speaking about the investments in research and development, and the press release was just released a few hours ago. And you will have a first-hand experience in discussing with them and understanding what's going on. So, speaking about tuberculosis, I think we all need to understand that there was huge progress in terms of TB over the last 10 years. And the famous, the treatment that was provided, which was, under a special package called DOTS, is functioning very well. Was functioning very well, and there were 56 million people treated from 1995, 22 million lives saved, and 45% reduction in TB mortality. So I don't know how many are you aware, but TB, tuberculosis, is a disease which is airborne, so it's spread through air. Therefore, all of us are at risk. It's not spread through any other things just by simply breathing. TB is a disease that is with us for thousands of years. So we know about tuberculosis since before, 4,000 years ago. I understand that they found traces of Mycobacterium tuberculosis in bodies of mummies and others in old Egypt. But being with us for so long time, unfortunately, we would have expected that TB is much more advanced and we are close to eliminating it. And you will see that actually we are very far from that. And that's why we need your help. It's a bit of a shame, because I said, in a way, the presentation I'm making here is not much different than my grandmother would have made to your grandparents. And this is very much linked not only with what's happening, but also to the piece on research that our colleagues from TAG will tell you a little bit about. This is a slide. You don't need to see the figures, but this is a slide that is presented everywhere, and you can see that there is a downwards trend for TB in terms of incidence and prevalence and mortality. And it's clear that these figures are going down. But then, are they going down fast enough that can deliver us something, or is just a simple slow going down? If you look over the incidence, which is the first slide, the rate of decrease is, for the last 7 years, 2% per year. So we go down, but we go at 2% per year decrease. And this means that if we want to go from the level that is right now, which is 125 per 100,000, this is the incidence globally now for TB, 125 per 100,000. If we continue going at the rhythm at 2% per year, as it was in the last years, to go, not to eliminate TB, not to speak about it out of our life, but just to go to the level that globally you will be at the same level as the developed countries. This will take us 170 years from now. Not to eliminate TB, but just to go at a very pathetic 10 per 100,000. So what I'm trying to make here the case is, unless we accelerate the rhythm of decrease of incidence from this 2% to something much bigger, not only that you will be here and your kids will be here, but the kids of our kids of our kids will be here, still looking at TB, which will, in the meantime, infect new others and make more suffering. So, in 2012, the recent released report of data of WHO showed that there were 1.3 million TB cases that died because of tuberculosis. This is a very small reduction versus last year, and the reduction is actually based on changing into the methodology in which the number of cases are counted. So it's not a real reduction in the number of people that die of TB. This is just slightly lower than what's happening because of the death because of HIV, and where I don't understand is that, you know, these people are dying with TB, which is it's curable and it's cheap to do it, and it's a 6-month treatment. It's not the burden that an HIV treatment has, and still people are much more aware and are very much keen to do much more for HIV/AIDS than are keen to do about TB. And that's why we need your support to go out there and explain what's going on and why it is so important to understand TB and to try to do something about it. Looking over where these people are, you will see that 40% are in Southeast Asia, very close to that are in the African region, and then you can see, you know, where the rest of people are spread. 700,000 of these people that die, which is close to half, are women. And in the African region, there are more women than men dying, which is pretty unique versus the other regions. The fact that we have so much in the African region is worrying, because the African region has not a huge population as the Asian region has. So it's absolutely clear that we have a very high burden in terms of people suffering and dying because of TB in this region. The other challenge we are faced with is that we are in the world estimated to have 8.6 million TB cases last year. And this was estimated to be people that had TB in 2012. Out of this, just 5.7 million of them were people that were reported and were treated and were diagnosed by countries. So we miss 3 million cases. And it's not that we missed 3 million cases in 2012, we consistently missed 3 million cases since 2007. So we are able to detect a certain number of people, but we are unable to reach to the missing 3 millions. And that's because the 3 millions are among the most vulnerable, the most key affected populations. These are, you know, among the people that are suffering, people that are, you know, for whatever reason have difficulties to reach to the public health sector. And, you know, it's easy for us all, we know where to go, we know what rights we have, we know how to you know, access. But if you are an illegal migrant or a worker, or you are extremely poor, or you are a sex worker or a drug user, you have a lot of reluctancy to enter into contact with any officials, especially if this is not made in a friendly, welcoming environment, and you never know what will happen with you, and they will find you with TB. So in TB, in addition to us being very having all these challenges in front of us in terms of TB, like the disease, we also are faced with this approach that we need to change the way we think, and we need to do some things for most for the vulnerable groups and the ones that are from the affected populations. For those of you more aware, you know, TB is a disease that takes 6 months to be treated and cured, and that requests some drugs to be taken. It's not easy because it's a 6 months long treatment, and you feel pretty good after the first few weeks, so you need to persist and take your treatment. If for whatever reason these first 6 months are not properly done, treatment is interrupted, drugs are not good, but people just decide to take today the red pills and tomorrow the white ones, and the day after tomorrow none, a form of tuberculosis is created, which is a form resistant to these drugs that are the first line drugs, we call them, the first one to be treated. MDR-TB is it's something that we should be pretty scared about, all of us, because it's a disease that takes much longer to be treated. It needs 2 years to be treated. In addition to that, it takes some drugs which are called second-line drugs, and these drugs are extremely expensive. They go just the drugs up to $6,000 to $8,000 per patient, US dollars per patient, which is a huge amount in most of the countries, I think everywhere. And these are just the drugs. But in addition to the financial suffering, to say so, of the pockets of governments and people sick with this, the second-line drugs we have right now, it's up to 42 pills that you have to take a day for MDR-TB. I mean, just picture that. And it's not only that you take this, but they give horrible, horrible side effects. 75% of people encounter huge nausea, so you vomit your brains out. You actually hate your life. And I tell you, those of you, and especially ladies, that, you know, we were pregnant and having nausea, that's nothing. You encounter a lot of psychotic effects, you have suicidal tendencies. Even the most, equilibrated person is encountering this. You encounter as well decrease in the hearing, loss of hearing towards deafness. So you are faced, and this is the drugs we have right now, so you basically have plastic bags of pills that you have to swallow over 2 years, and they give you horrible side effects. MDR-TB, as I said, is not created by the nature, it's created by us and by people and by healthcare who manipulated wrong the first-line drugs. It's an antimicrobial resistance, right? And we estimate that there are around 500,000 MDR-TB in the world. Just 77,000 of them are diagnosed and treated. The remaining part, again, is out there suffering or dying quietly, but also, and I'll come back to that, unfortunately transmitting the disease. When even these second-line drugs are bad manipulated, you create an additional resistance. You create a superbug resistance to almost everything we have right now. It's called XDR-TB. For people living with HIV, having XDR-TB is a death sentence, because this is resistant to almost what you can take, what we know we have right now. And it is estimated by WHO that 10% of all MDR-TB cases are XDR-TB. So we are having, of which just very few cases, probably around 100, are known and treated. So the rest are there again, spreading and infecting the others. We have 7 billion people in the world right now. Out of that, 2 billion are infected with TB. I am infected with TB. Those of you coming from countries with a high level of TB, we are all kind of infected because it's a lot around us. But infection doesn't mean sickness. We carry this with us. And whenever our immune system decreases for whatever reason, HIV/AIDS being one of them, absolutely, it is said that 10% of those infected will develop sometime during the lifetime tuberculosis. So what I'm trying to say is that we have a huge reservoir of people sick with TB, that we will have people infected with TB, and therefore that will become sick with TB, that we will have to work around if we really want to get rid of this disease. And as I said, every single case of those 3 million that we don't find, of those 400,000 MDR-TB that we don't find, or of those 50,000 XDR-TB that we don't find, are transmitting further. And every single case that is not properly treated or diagnosed can infect up to 10 people per year, and for MDR-TB around 4 to 7 other people per year. So we continue this chain of transmission. This is just speaking about the MDR-TB. I gave you already the numbers, and what I actually hear, what is the most important piece for you, is the fact that, as you can see, there is a very small number. The blue block at the end, the very minuscule, pathetic one, is the cases of MDR-TB on treatment. And you can see the blue box in the beginning, that is how many we should actually find and put on treatment. And we are so bloody far away of that. If we speak of where are most of the 3 million of the cases missed, this is in what parts of the world We have, there are like 12 countries of the world that are missing most of the 3 million cases, with India accounting of a big percentage of that, but as you can see, there are others as well. As I said, TB is an airborne disease, is spread through air. We need more basic science, and we need more basic research in identifying what's happened when it's transmitted. When I was a student, we used to learn that it takes up to a month to 2 months to stay at a conversational distance with somebody who has TB to infect the other one. The most recent data from KwaZulu-Natal, when we had a lot of XDR TB cases, it shows that it can be as less as 4 hours of sharing of a waiting room of people with MDR, TB and HIV to ensure transmission. And I think you all saw the cases that were reported of transmission during flights. The duration of a flight of over 8 hours, in which you have some people coughing and then infecting the others. So it's just infecting it, it's not making you sick, but if your system, for whatever reason, cannot fight it, then you will become sick with TB. So here I just show that actually the number of airline flights since 2000, especially in countries with high MDR TB, increased by 200%, which shows that there is a lot of MDR traveling by plane around there. Obviously, and this is not just for TB, but TB particularly is a disease associated with poverty. And it is not only, Nelson Mandela said something very wise about TB. He said, TB is the father, but as well the son of poverty. Because on one hand, of course, that, all the poverty pockets and all the people that are at big risks are coming from poor, especially from the poor and marginalized one. But in the same time, through the effects it has, TB is actually fueling poverty. And you can see here, actually for me, the most striking figures were the first one, because if it says that 75% of people that are dealing with TB have to take a loan to be able to go through the treatment. And I don't know, probably most of us here are going through a loan taking, or we have loans as well. And we know that it's difficult for us having jobs and knowing where to go, but imagine what means a loan for somebody that is really poor or have a big family, and or is a migrant or a migrant worker in a country. And 50% are having a decrease in their yearly income. There is hope though, and again, you will see a bit more in detail from, there is from my colleagues, and actually there was a lot of work showing that we can move this very horrible situation of reaching some of the bold targets by 2180, and actually we can accelerate that and be doing much better by 2035. But that will not be easy at all. It requests a very big push of scaling up of what we have right now. What's happening in TB, if you go in countries, we have great examples and projects, but they are very limited and they are very, it's like pilots, right? It's not full scale up in a country. So you just need to have countries bold enough to say we will scale up. We will need to prioritize, as I said, and try and find and diagnose and cure the most vulnerable, including women and children. We'll need, obviously, this should be put in the country context and should not be taken out of it and, implemented something that worked in Kazakhstan. It will not necessarily work in Kenya, even though they start both with K. And we will need new tools, and you will have our colleagues from TAG referring to the new tools much more in detail than I do it here. And it's not only that there was this modeling happening, which people can say it's a pie in the sky. We actually noticed, and we have evidence of what can work. And it shows that if you are really focused and you try to address and put your efforts towards certain vulnerable groups, you can increase 25 times the number of cases detected and treated. We have an initiative in the Stop TB Partnership called TB Reach, which is giving grants to people, to institutions, to countries that are interested to think innovative and out of the box. And we say just that. You take this money and you need to find additional TB cases in whatever way you think it will work for you. Is it because you think that people are hanging in a restaurant? Go in the restaurant and find them. Do you think that they are going and having parties in a bar? Go in the bar. We don't care. Just come and find additional cases from the vulnerable groups. We had great surprises. We had a project in Lesotho in which actually they didn't want, it's fancy to ask microscopes or drugs. they said, no, we have this. We don't have our people reaching this. So they asked donkeys. So they said, with the money from you, we want to buy donkeys. Then the donkeys will transport our health workers to deliver the drugs to the patients, or we transport patients to the hospital. So we gave them money to buy the donkeys, and actually Global Fund, which is the biggest donor for TB and HIV and malaria, took that up and is scaling it up as well. Through the as well TB Reach, we show that it can double the number of cases detected and treated if you work with the community workers and if you go to the grassroots. It's in, we used to be in TB very vertical, very medicalized. It's time to have a voice in the ground and in the civil society level. It's very fancy now, and a lot of your leaders or those listening to what you write or put out there are speaking about return on investments and value for money. Why would we invest in TB? This was not done for us. This was done by the high-level panel that put it together, the MDG, the post-2015 priorities for sustainable goals development. And it looks like TB, when compared with the other diseases, in terms of case finding and treatment, provides a very good return on investment. For every single dollar, you can get back up to $30. So why we have this sense of urgency, and why, especially as you will hear from our colleagues from TAG, we were all very, very upset with this decrease in funding for research, is that we need to act now. You see, every delay now will delay several years the expectations of us reaching something. So it's not only that, okay, 1 year passed, it's the fact that this 1 year past will completely wipe any hopes that we have for future, but also means a lot of people that die completely unnecessary. And we very often forget, and especially me coming and speaking about this from Geneva, we just have these slides, you forget the human aspect of it. I can tell you that when it scares you, or when it's about you, and when it's happening to somebody you care, this brings back all the human aspect and what implications this have. It's not easy to have that in mind all the time, but once that strikes you, you cannot turn your back around. What I wanted to thank you for the attention, and what my hope is, if nothing else, you become little advocates for TB as well. We are unable, for whatever reason, to maintain the attention of decision makers on TB. It's probably because a lot of our patients are really those that are poor, and it's not easy. I'm coming from Romania, from Eastern Europe. A lot of our patients are, alcoholics, and it's very difficult to deal with them. They don't have a voice, Doctor will not even invite them in the cabinet for most of them. It's a nurse somewhere on a corridor. I mean, it is very difficult to be in the minds of politicians and decision makers when you deal with this kind of patients. We are a different crowd than HIV, fortunately or unfortunately, but we try to work, and we are working actually very good with them, and try to learn from things that worked for them and try to build things together. But the least of you can do is keep TB in the mind when you have to write something about the global health. And I want to thank you for your attention.